Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. All right, hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Doug Maynard, your host for the next hour or so. Spark Live is where we gather each Wednesday to curate and convene and showcase excellence and innovation and new information from across the child and youth healthcare community, with always our goal to spark conversations, ideas, and action. And when we do spark those ideas and conversation, please don't hesitate to put your comments or questions into the question box. There's a question box in your control panel, usually on the right-hand side of your screen, and you can put those comments and questions in as you think of them. Don't feel you need to wait until the end of the session when we take the questions. Just put them in at any time, and we'll have them ready to present to our speakers. And also, don't hesitate to share your thoughts on Twitter, and be sure to tag us at Child Health Can. And speaking of Twitter, if you do follow us on Twitter, please, you may see a lot of our tweets from Children's Healthcare Canada around Pink Shirt Day, which is around the anti-bullying campaign around Pink Shirt Day. So you'll see the CAFC staff wearing their pink shirts in support of Holland Bloorview Kids Rehabilitation Hospital in Toronto. They've got a Dear Everybody campaign, which is focused on preventing stigma and addressing stigma around children with disabilities, and often children in schools that have disabilities are subject to bullying and other things like that. So we're trying to put a focus on bullying on Pink Shirt Day around children with disabilities to support and address stigma in that area. And I can see, Durhan, you've got your screen up, but we're actually looking at your presenter screen, not the, if you can switch to the other screen, that would be great.
Do I know how to do?
Yeah, if you can just look at your settings and just switch to the other screen while I finish the introduction, I'll see if we can get you squared away. Otherwise, I'll be back with you in just a second, because that was our speaker, Dr. Durhan Wong Rieger. And today we're going to be talking about Caring for Rare, Canada's national rare diseases strategy. And this is today being Pink Shirt Day. Tomorrow is, in fact, Rare Disease Day, February 28th. I believe Thursday, the 28th, is International Rare Diseases Day. And today we're here to talk about rare diseases and the vision of a national strategy, and where we are today as far as realizing that national and potentially a global strategy for rare diseases. So with that being said, it does look like Dr. Wong Rieger does have her slides in the right order. Or in her screens in the right order. So it's my pleasure to introduce Dr. Wong Rieger, who is the president and CEO of the Canadian Organization for Rare Disorders. If you look at her bio on our Knowledge Exchange Network, you'll see she's also a million other things, a few of which are the chair of the Consumer Advocare Network, president and CEO of the Institute for Optimizing Healthcare Outcomes, and she also participates in a number of international organizations all focused on rare diseases and a few other things. So be sure to check out her full bio there. We do also hopefully have Sabrina Milson joining us. And she's been having a little bit of difficulty connecting to the presentation. So hopefully we will get her, because she has a very important part of this presentation. She's actually a staff at Hamilton Health Sciences in Hamilton, but her role today will be to join us to share her story as a parent of a child with a rare disease. So hopefully we'll get her online shortly, and we'll be able to hear her story as well. But in the meantime, we're going to hand the virtual podium over to start off the presentation over to Dr. Durhan Wong Rieger. Over to you, Durhan.
Thank you very much, and I can't tell you how pleased I am to be here. We did a presentation around transitions for children with rare diseases between adolescence and adulthood, And that was a number of years ago. So it's been a little while since we've had the opportunity to join you, but we are just so very pleased, especially right now, because we are just one day away from the official Rare Disease Day, which is always the last day in February. So this is the 12th International Rare Disease Day. In Canada, we have been part of those activities from the very beginning in 2008. And next year, being leap year, Rare Disease Day will fall on February the 29th. And as you can see, that's because it is a rare day. So that's one of the things that we do internationally as a rare disease community. What I'm going to do here is to talk to you a bit about what's happening in rare diseases in Canada. And you'll see it says Canada's Rare Disease Roadmap. Is there a roadmap? I'm going to talk to you about where some of the advances we've made, some of the challenges we continue to make. And then I hope you'll indulge me in talking a bit about what's happening internationally, because it is so important for us to understand what Canada is doing relative to the rest of the world, and in some areas where we are doing well, and in other areas where we may need to really think about how do we redefine how do we dealing with rare diseases in Canada. Hopefully Sabrina does join us, because I think, as you heard, she has a very important personal story. She's one of the many thousands of stories that we have here. And that was the reason why, in fact, we believe it's so very important for us to be raising the issues around rare diseases. In fact, I'm going to start with you with a bit about CORD. We are a national organization. We're a network of about 102 patient groups. So, we are a affiliation of patient groups more than we are actually individual members, though we do have individual members, and we have other types of members as well who are not necessarily patients or patient representatives. And as you can see, fairly straightforward in terms of our mission, our mandate. We at CORD really feel that our role is to advance rare disease policy, and that really is looking at what are the policies and programs, sometimes on a federal level, sometimes on a interprovincial level, but also within provinces and within institutions as well. And really looking at the key components of the importance in terms of screening, diagnosing, getting patients access to the right kinds of treatments, especially clinical trials, making sure that patients and patient groups who are the backbone really of rare disease communities are in fact supported, and also obviously supporting research. So I'll start with that, just a few little vignettes here, and again, maybe helping you understand a bit of what we're doing. This is a gentleman who is was on our board of directors until this past year. He just stepped down. As you can see, he's a father, and his story is quite poignant. He says at 33, he got a diagnosis at about the same time as his 2-year-old daughter. And he talks about the story because, he had all his life suffered from these symptoms, which nobody could actually diagnose. And in many cases, his family, his parents were told that, they were either imagining things or they were really not that serious and he should just go home. And as he said, when she was born, he recognized some of those same symptoms. And it was like, he says, okay, it was our time to get really serious there. And some of it was serendipitous, because just about that time was when a new therapy came into place for the condition that she has, Muckle-Wells. There was actually a Center of Excellence at Sick Kids, an amazing physician who's there, diagnosed the little girl. And as he said, at the same time, he got a diagnosis, and both of them now are on the same treatment. And what he says is very important, and that is that, thank gosh, she will never go through the kind of pain and suffering that he did. So this is really important, getting that diagnosis, getting it early, and being able then to get access to treatment. And as we know, more and more treatments coming on board really give us the opportunity to do more and more for patients. But first of all, we got to get the patients to the diagnosis. This is a second story, which I think is quite nice. So this is a woman who has Cushing's disease. Quite unusual. Oftentimes not diagnosed until much later in life. So many of our rare diseases are, in fact, pediatric conditions, but not all of them are. Obviously, they're genetic conditions. So she's had Cushing's her entire life, but in fact did not become symptomatic until later. It really is caused by a tumor that's in the brain. were able to, as she says, successfully remove the tumor, radiation, and some chemo, but then other conditions came as a result of, and of course complicated by it. The problem was that the medication that she needed in terms of her condition was not available in Canada. And then when a new treatment came on, it became a large battle in trying to get access to it for patients with Cushing's. So this is a lovely story, but again, the reason why the mom became very active and is doing, extremely well. She also works in the healthcare system, and she also says, quite interestingly, that because she's knowledgeable, she was actually able to get ongoing support. She's a nurse in the hospital in BC, but again, very concerned that other people are not in the same fortunate position. This is a lovely young gal who is actually daughter of one of our staff members. She has thalassemia major, has obviously had it all her life, was diagnosed when she was an infant, has been on treatment. But thalassemia is a blood disorder, I think as many of you will know, requires transfusions about monthly. It requires daily chelation therapy in order to remove the excess iron from it. This gal is amazing. She is a athlete, as you can see here, plays volleyball, plays soccer, is on the gymnastics team, cheerleading. She's actually now in her third year of university at Queen's and just thrives. And basically, I think if you were to talk to her, would never, ever know that she has any kind of a chronic disability, and including one that requires a lot of care and treatment. And from her perspective, she just deals with it. And it gives her, as she says, the courage and the motivation to continue to do more. So this is what can happen, as we say, when you get patients to the right care and treatment. This is my last little vignette here. This is unfortunately a sad story because it's still, and the patient is very much alive, so I don't mean that in any way. But an access to, again, this is a patient who has UHS, uremic hemolytic syndrome, and he's absolutely an amazing atypical hemolytic uremic syndrome. He's absolutely an amazing man, diagnosed quite late in life again. Has had, it's again an ultra rare blood disorder. There is a treatment that is available, but it is not available to him. He has a cousin who's actually on the treatment. And what happens eventually is that the disease destroys the kidneys. He's had a kidney transplant, one that was donated by his wife. He's allowed to actually get another transplant, but as the doctor says, no use our giving it to you, because unless you've got access to the therapy on an ongoing basis, we're not going to be able to, have any kind of real success with it. So he's been on daily hemolytic dialysis probably think the last 6 years, which, as you can imagine, is a huge burden. It means he's no longer able to work, and he's had to be at home. His wife, is sort of a full-time worker there. They're an amazing couple, continue to fight for access, but because of the very particular way in which this therapy is actually reimbursed in Canada, he is not eligible for treatment. This is a man who, if you lived in the UK, would actually have access to treatment. If you lived in France, would have access to treatment. If you lived in many other countries, he would actually be on treatment. If he had private insurance, he would be on treatment. But unfortunately, because of the way in which our system funds drugs for rare diseases, it will leave out many patients who are not able to get it through some other means. If he had a different condition, it's also indicated for PNH. And proximal nocturnal hemolytic syndrome, he would actually be on treatment. But unfortunately, because he has a different condition, he is not eligible for treatment. So this is some of the challenges that we have. I'll just give you some quick stats in terms of what we have here. These are some of the key stats and why we're talking about the importance of it. Rare diseases, by some definitions, are diseases that affect maybe fewer than 1 in 2,000 people. Actually, they can affect many of them are actually much, much rarer than that. And the number is not really that important in that different countries actually have different definitions. It's kind of a made up definition when you think about it. There's nothing that's actually, sort of grounded in kinds of biology or science about it. It just looks at the issues for patients who, because their numbers are small, have a very difficult time in terms of sometimes getting to a diagnosis because physicians, Professionals don't actually recognize the conditions, oftentimes misdiagnosed, obviously. Because the conditions are small, there's oftentimes not good guidelines and standardized care for these conditions. So they're oftentimes, their care will vary depending on where they are or how much they have access to a real specialist. The number of specialists are few. The research into these conditions are few. So again, we know very little about them. And of course, the development of treatments are actually very, very problematic because, again, the number of patients who could benefit, the number of patients who go into clinical trials are actually very small. So we have some huge disincentives for the development of treatments. And even though we hear, as you see here, the thing is, though, that there are up to 8,000, between 6,000 and 8,000 rare diseases. Again, the exact number is not actually known, depends a little bit on the definition, and the fact that we've got many rare diseases that have never, ever been identified. What we do know is about 2/3 of those are rare diseases affect children. And in fact, most of them would be, if they're genetic, would actually be with you from birth, but they may not become symptomatic until much later. The really sad news, as you can see there, is 30% of those children who have a rare disease will not reach their 5th birthday. And there's lots of reasons for that. They may not be diagnosed. They may be misdiagnosed. The opportunities for intervention early on that might have prevented symptoms or actually prevented death are not provided sufficiently in time. Or in many cases, there simply isn't a treatment. There is no cure for this condition. So the children, do die. And this is, a statement that obviously is one of the reasons why we're working the way that we do. 80% of them we say are genetic, but 50% have no family history of it. That means that they're either very rare and unknown, or in many cases, obviously, it's a spontaneous mutation. And we have lots of conditions that are, in fact, rare conditions that have a genetic history. But in fact, even for instance, for hemophilia, which is one of the most prevalent rare conditions, about 10 to 20% of those will be spontaneous mutations. Only 5% of rare diseases have an approved treatment. This is a huge fact. Though we hear a lot about rare disease treatments coming in, what we know is that at the end of the day, there's about 750 approved treatments in the U.S. In Canada, we don't have nearly all of those that are approved, fewer than 500 in Canada. But that really only covers about 500 diseases, meaning that with potentially 6,500 conditions for which there are no treatments whatsoever. And this is, again, why we have a huge need. So, which gets us to why we want to have a rare disease strategy. I'll put this up here, but before I do, I'll give you a slight preamble. A rare disease strategy from our point of view is essential because it really will pull together all of the issues around rare diseases that are not happening now. So what can we do? It will improve early detection and prevention, obviously provide access to care, making sure that we have community support. As I said, in many, many cases, because there are no specialists, because there are no known treatments, the community and the patient associations, the patient groups, the parents groups are the ones that are actually providing their own support, providing sustainable access to promising therapies. As you saw some of the issues before, even when the therapies are there, we have a hard time getting and making them available to people, and then continue to promote innovative research in all aspects of rare diseases. I'll drill down on this a little bit more, but I won't, dwell on it. Really, newborn screening, I think as some of you will know, is one of the most important tools that we have, quite effective against some of the most commonly well-known genetic diseases, especially those that are potentially single gene defects, can be identified at birth with a single drop of blood. You can actually detect up to, the best state, I think, in the U.S., which is one of the leaders in newborn screening, will test for 60 conditions that can be identified at birth. In Canada, we vary a lot. Ontario is one of the best provinces. We test for like 33 of them. Saskatchewan tests for maybe 34, 35 of them. Most of the other provinces lag considerably. And the problem is that it varies across the provinces. If you live in one province, you may in fact be able to be picked up, in another province not. Even though in 2016, the provincial health ministers came together and said, okay, we will standardize newborn screening. We will ask all provinces to test for at least 23 standardized, the most standardized tests that there are for rare diseases. Today, it still varies across the provinces. I think in Quebec, we're still only testing for 6. I think in Nova Scotia, we test for something like 12. The problem is that, there is no enforcement in terms of it. And again, then we will be missing children who could be picked up. We'll be missing children who will be picked up in one province, but not necessarily on another. What you can see here, you can't do anything unless you get a diagnosis. And I think those vignettes show that. The problem is that it is a long, long wait to get to a diagnosis. 20% waited more than 6 years for a diagnosis in a survey that we've done. 2 out of 3, patients get a misdiagnosis before they get the proper one. Our research suggests that patients get between 7 and 14 misdiagnoses. They will see 5 specialists before they get to the right diagnosis. And sometimes the children may be, much older and well advanced in their disease before they get to the right diagnosis. And again, it's not anybody's fault. It isn't as, in some cases, people are willingly turning a blind eye to it. But in fact, the symptoms may actually be quite common and may mimic other conditions. And unless, one really drills down further, you're not able to get to that diagnosis. And this, again, why we need a rare disease strategy. We need a rare program. We also know that there's so much more we can do in terms of diagnosis because of the new kinds of testing as well. Exome genome sequencing can actually diagnose every condition. That is a genetic condition. We may not be able to effectively know what to do about it or even to effectively label it, but we can, in fact, do a great deal more. We have terrific capacities for exome and genome sequencing in Canada. Unfortunately, we don't use it for routinely for clinical care. It's used in research, and that's a real problem because in many respects, we are missing many conditions that we could be able to do. In addition to just the testing, obviously we want to get people to genetic counselors. And again, in some cases, there may be things you can do to intervene when they're early on. And you can also avoid, parents having another child with the same condition if they do not, just because they didn't know. Obviously, it's still up to the parents, but getting people to counseling. And we've seen the cases where, we'll be into the 3rd child with the same condition before they're actually diagnosed and picked up. And this is not something that we want to have happen by default. So good genetic testing guidelines. Genetic tests are linked to registries so that patients can be automatically enrolled in a registry when they're diagnosed. And again, as treatments, as other care comes out, patients can actually be notified, can be followed up, etc. And to then have early detection and prevention services across Canada. Theoretically, we could genome sequence everybody and be able to identify, through those genome sequences, any potential rare disease. Obviously, in many cases, we may not want to because they may never become symptomatic, etc. But we can do it. And we should be doing a great deal more. We should be standardizing what we're doing. We should be doing it to the best of, the standards that are available. So this is one of the things. Let me move on here. Goal 2 is obviously making sure that we have access to care. Sorry about that. Clinical practice guidelines, disease registry, comprehensive care and support, centers of excellence, and virtual networks. In Canada, we have many, many specialty clinics. We have amazing specialists. The problem what we have is that we don't actually have designated centers of excellence. We don't actually have the ability for other physicians to refer and know these centers exist, and we also don't have the capacity for having them serve patients beyond their, in some respects, beyond their geographic boundaries. And this is quite different from what's happening in other countries. In Europe, there are centers of excellence, around 24 clusters of rare diseases. So not every rare disease obviously has a cluster. It should have its own specialty centers. These are European networks, meaning they're virtual networks that exist and serve all patients in Europe, and that patients then can be referred to the appropriate center of excellence, regardless of where they live in Europe. So I can be in Poland, I can identify a child with a very specific blood disorder. That child can be referred to the center of excellence in Spain. They will be diagnosed in that center, sometimes without the patient even having to travel there, but if necessary, they can travel there. They get access to the right kinds of expertise in terms of defining what the standardized care ought to be. And then there are they get support back at home, because the support is also given to the center that's in their home country, but also could be even down to the village and where they live, where they've got a general practitioner who can follow up with them. This is what we're talking about. We also know that we need to have these centers that are linked to other services. It's not just about the healthcare part, the social care, education, disability, work support. With rare diseases, as with many chronic diseases, there are a host of other issues, including disabilities, including psychological issues, and those are issues that delays in terms of education. I think those are the kinds of things that we have support for in the environment, but our patients oftentimes don't get to them because either they don't know about them, they're not directed to them, or in some cases, if those are designated on a particular named disease basis, then they don't even get access to them because they're not in that disease list. Our goal 3, as we say, is connecting them to patient supports. There are many, many patient groups. And in fact, of our 102 patient groups, many are family-based groups. They start because they have a child with rare disease. There's nobody else that's around to provide and support. Importantly, as you can imagine, many, many of these patients then are connected internationally. There are international and support networks that they can belong to, virtual networks. In Canada, we have just acquired ownership of the biggest international patient support network in the world called RD Connect. And it's a wonderful resource because it's made up of many, many patient communities within it. So you can join, subscribe to a specific patient community, and then actually have access to other patients. It is available in, I think, 6 to 12 languages, so that you're connected with patients around the world. You can speak in your own language, type in your own language, it will be translated, and then you may get responses back. So it's an amazing resource, especially for very rare diseases. So we are, that is available. Unfortunately, Canada, again, provides very little support to patient organizations to actually help them to be able to provide what is a vital function, and in many cases, sometimes the only support that these patients get. Access to promising therapies, that is one of the things that's obviously huge. As we say, even when the therapy is available, what we know is that many of the patients can't get access to them, and they are definitely expensive. They're definitely challenging in terms of their management and monitoring, but that doesn't mean that we shouldn't be putting in the efforts to make sure that any patient who might be eligible for a particular treatment that is appropriate can be able to have access to it. It's almost that old question of what's the worst thing, not having a treatment. The worst thing is really knowing there's a treatment there, but you can't get it, or you can't get it for your child. And this is, something that we really need to make sure does not exist in Canada. And there are many programs that are available. Hopefully I'll get to that point to talk a little bit about it. And then engagement and research. Canada actually does a great job in terms of rare disease research relative to the kind of resources that we actually have. We are involved in many, many international programs. CIHR, Canada, support those research initiatives. Many of the hospitals that we have, CHIO, Sick Kids, Vancouver Children's Hospital especially, but also in Alberta, Quebec, there are major, sites in which research is being done on rare diseases, sometimes very, very small patient populations. And we also contribute and participate in international research projects, which is, essential when you think about the size of these. So in many respects, we do a considerable amount in terms of contribution in research. The challenge sometimes getting that research out to patients, clinicians, getting them engaged as well. This is a launch of our rare disease strategy, which we actually launched, as we said, on Parliament Hill. We created it in 2015, brought it to Parliament Hill in 2016, have taken it across the country, trying to get support from many different people in terms of how do we actually make this, a real thing. I mean, we have a cancer strategy, we have a heart disease strategy, we have a diabetes strategy, we have a mental health strategy, and we've seen the benefits of all of those. What we need to do is make sure that we have a rare disease strategy. And what we know is that even though there are 7,000 different rare diseases, there are common approaches to these rare diseases, including things like diagnostic tests, including things like, centers that we can cluster that actually make it so that we're not talking about treating 7,000 different diseases, the same as we can cluster cancers and talk about them. We had some early wins, so the ministers did recognize that they need to have long-term solutions. The Ontario minister, February 2016, on rare disease, they committed to establishing it as a pilot in an early Danner syndrome clinic. and actually then created the first working group on developing a rare disease strategy for Ontario using our strategy as a platform, which was pretty amazing. Creating Rare Alliance Canada, then bringing in other stakeholders that can actually participate with us in trying to implement and oversee this rare disease strategy. These are some of the centers of excellence that we were networked with and recognized as being really critical in terms of the advancement of rare disease treatment and within hospitals, but also as support networks. I'm going to switch then very quickly to talking a bit about the orphan drug regulatory roadmap. In Canada, we do not actually have an orphan drug policy. We don't have orphan drug legislation per se. But it is not to say we cannot do a very good job in terms of bringing in rare disease drugs. After lots of lobbying, after lots of working with the Health Canada, we actually were able to help them create what they call this roadmap or a regulatory approach to orphan and rare disease drugs. And quite frankly, built into the notion of what's a life cycle approach. We think it does a reasonably good job in terms of being able to provide access for rare disease drugs that are being brought into application, providing the right kind of support, getting them approved and into the market. So, Canada for many years lagged behind every developed country in being able to establish clinical trials, recruit new drugs coming into Canada. We still lag considerably, but in some respects, we've done a great deal more now, especially with understanding that these are drugs that have very specific, needs, especially given the fact that the clinical trials are often done with very small patient populations, and that many times, because there's an urgent unmet need, they will be brought to market or they will apply for application after only phase 2 trials. So promising, huge need. Can we get them available to people? And oftentimes approved on those phase 2 trials with ongoing post-market, monitoring. So this is just to say that if, it really does provide a lot of benefits, including support for the clinical trials, also providing support for getting it through the application. The important thing that we're recognizing is that, Health Canada, as many regulators do, work with the developers, work with the drug companies to actually make sure that as they're doing these clinical trials, they're collecting the evidence, and they're collecting evidence in the way on the right kinds of outcomes so that when the clinical trials are done and you're providing them for approval, they actually can be approved. Obviously, the big challenge beyond that is getting them reimbursed, as we heard earlier. Some of that is actually changing a bit as well. So I'll kind of get to that quickly, hopefully. And different kinds of innovative clinical trial designs. This, I think, is really important. Recognizing this, as we say, these are very small patient populations. So in many cases, you cannot do a traditional randomized control trial with, hundreds of patients in each arm and be able to demonstrate, whether it works. You really have to make the clinical trials designed around the feasibility of the patient population. And we're seeing things like that, outcomes relative to natural history data, outcomes relative to best practices without necessarily having to have everybody on a placebo. You see things like switchover trials where patients can start and then be switched over into the treatment if in fact the drug serves proving without necessarily jeopardizing the ability for the clinical trial to demonstrate that its endpoint. So all of these things are really ways in which we can help expedite and the approval of a trial for a rare disease drug without jeopardizing, on the other hand, the scientific evidence that is necessary to ensure that the drug obviously is safe and that it does work. So these are important elements. And Canada has been very late to this game. I mean, the US began this in 1983. The Europeans did this in 1999, 2000. Other countries, including Japan, Switzerland, Australia, have all introduced this kind of regulatory support much earlier. We're very late to the game, but I will say is that we seem to be doing a reasonably good job of it. The challenge is because we're so late to the game, many companies just think that Canada is just not a good place for rare disease drugs. When I said earlier that we don't get all of these drugs in Canada, in many cases, population is small, but also the fact that they're not assured that we are a great place in order to do clinical trials or a great place in terms of proving these trials. Companies will not come to Canada early on. And as you may know, in some cases, when we're talking about unmet needs, we're talking about progressive, we're talking about life-threatening diseases, for many of these patients, the only way you get access to a drug in a timely fashion is if you're able to enter into a clinical trial when it's available. And in many cases, many of our patients end up going to the States, as you know, to get access to clinical trials. That's changing. Health Canada is actually putting up clinical trials. We're trying to do a better job in attracting clinical trial sites in Canada, because we not only want the patients to have access to the clinical trials, we want to develop the expertise in Canada. We want to develop clinical sites in Canada that actually have that expertise, so that when these drugs come out, that we are actually ready to be able to treat patients. So really important for us to be able to promote how Canada is, in fact, supporting the research and development in terms of these drugs, and really wanting to make Canada, a good place for it. Clinical trial registration. So this is more information about how is, in fact, that one can register clinical trial. We have clinicians in hospital who are actually doing, research on drugs as well. And again, the support can be provided by Health Canada to actually help you design your clinical trials, help you figure out how you're going to register the patients, and also, if we get to that point, how do you actually apply for approval? So these are important. The challenge we have in Canada, obviously, is reimbursement. And this is the, challenged by the fact that these are expensive drugs, but also challenged by the fact that we have a very, very complicated reimbursement system, as you know. And this is just to show you, and of course we have a private payer system versus a public system. What we do know in Canada is that if you have a private insurer, you're much more likely to get access to your rare disease drug than if you have to rely on the public system. I think as some of my examples showed you earlier, and this is a tragedy. What we're trying to do is actually change that. At the same time, we have a very aggressive campaign coming out of the federal government that says we just need to reduce the cost of drugs in Canada, where we pay way too much for drugs, and we're going to be on a path to try to figure out how we can make those drugs cheaper. And unfortunately, the way they're going about it really disadvantages the rare disease drugs even more. The really almost in the crosshairs of what the Canada strategy is are these innovative therapies for rare diseases, and they almost mention them specifically. Let me kind of make a point to you, is that it is not the rare disease drugs that are the problem for the huge amount of expenditure we have in terms of medicines in Canada. Whether or not we're spending too much on drugs, I think we do need to take a look in terms of how we can make sure they're accessible. But rare disease drugs in Canada count for only about 3.5% to 4% of the total drug spend. It is not the rare disease drugs are really crippling the drug budgets. There are many other places that are there. And we can also guarantee you that even though many of these drugs may be very expensive, they only go to patients for whom they're absolutely appropriate. They're highly monitored. Patients stay on therapy. We monitor the outcomes. And frankly, in many of the provisions we have, if they don't work, the patients come off the therapies. It is not where we should be focusing in terms of trying to keep these drugs out, or trying to just consider whether or not these are the most troublesome in terms of our drug budgets. And unfortunately, the way in which Canada is developing their new regulations for price controls, they're focusing strongly on these drugs that are for rare disease patients. We've got to figure out a different way. The other thing, so this is a summary of it. I won't go over it. If you're involved in it, you know what I'm talking about. If not, it is important to take an understanding, because it will affect what drugs will come to Canada, innovative drugs for all conditions. And this is a huge problem for us in the patient community. This is their proposed scheme. I won't go into detail again. If you are involved in it and aware of it, I think it's something that you hopefully are helping to take action on. Because otherwise we will introduce a scheme that puts us at a huge advantage of every other country in terms of trying to attract clinical trials and bringing in innovative therapy. National Pharmacare, I think, is something that we've looked at as well, and as many of you will know, introduced by our past Ontario Minister Hoskins in leading up the a program to introduce National Pharmacare. I will tell you is what we've asked for in terms of rare diseases is to have a specialized program for rare diseases. And interestingly enough, in the middle of our National Pharmacare consultations, this proposal came out from a group that had been set up with, as you can see, about 4 or 5 years ago now, the Expensive Drugs for Rare Diseases program, and they proposed a managed access scheme. Again, not to go into deep detail on it, but what it basically says is that we know a lot of these drugs come to market, low levels of evidence around their long-term benefits, but enough to justify the fact they should be on market, available to some patients. A managed access scheme simply says, how can we bring these drugs to those patients in a way that will continue to monitor them while they're on therapy? We bring on the drugs, for patients who have most urgent need, those for whom they may be effective based on the evidence. We enroll them, we monitor them, see if it works. The other part of this is really important. It's a risk-sharing scheme. So companies then are asked to help support or even totally fund those the first rounds of therapy while we try to decide whether they work. If they work, they move into the actual reimbursement. If they don't work, the patients are moved into something else. They don't continue on that therapy. It is something that we use now. We just never standardize it. And it is something that we strongly endorse. To be honest with you, it's the same scheme we brought to the health ministers back in about 12 years ago. So a little bit 12 years later, they finally picked up and said, oh, this might be a good idea in terms of how we should address this. It's okay. We're willing to work with them. And this is some of the actual reviews around it. I won't go into detail, just to let you know that we're working with them. We're hoping that we actually have some pilots, have some guidelines for it, and that we can begin to bring those drugs in, because it will help us in terms of what is currently sometimes a 2.5 to 7 year delay after the time a drug is approved before it actually gets to the patients that need them. And in many cases, as you can imagine, some of these patients actually do not either survive, or their disease has progressed to the point where they're no longer eligible for the therapy. And this is something, again, we have to make sure it does not happen. So we're very supportive of this process, trying to work with them on it, hoping that it actually does come into implementation. And because, all 9 provinces have come forth to say, Quebec does its own version of it as well. We're very hopeful that this will actually happen. And this is just my last slide to show you. It's a trip that we took to the Arctic Circle a number of years ago. Took a group of patients up there just to show that, rare disease patients are just like anybody else. We can do just about anything. And I'll end it at that. I don't know if Sabrina got on here.
I am on. Hi. Hello.
Oh, sorry about that. I should have probably flipped to you earlier. Thank you so much.
That's okay.
I'm going to flip up your slides because I think you can pretty well introduce yourself, right, once I get into it. So can we do that just in the interest of time? I'll flip your slides up. You can see them, and then hopefully I'll let you take it over from there. We're just so delighted to have met Sabrina. And I think, as you heard at the very beginning, she's a healthcare researcher in Hamilton, but here's in her own right is going to be talking about her experiences, and hopefully, giving us some first-hand example of the challenges that we're talking about. So, Sabrina, I'll give it to you, and just tell me when to flip to the next slide, okay?
Oh, perfect. Okay, can you just, I think that there's a slide before this one.
Oh, there is? Oh, yeah, sorry about that. Gosh, the most important slide. What's the matter with me?
No, that's okay. It's all good. Thank you very much. Hi, good morning, friends. My name is Sabrina Milson, and this is my beautiful daughter, Ella. For the past 18 years, I've been advocating for children with rare diseases. As a clinical researcher at McMaster Children's Hospital in the Pediatric Hematology Oncology Division, I've seen many families struggle to find the answers and support needed to navigate a complex medical system. Helping families and their children has always been my passion. Today, I will share with you my experience as a parent's perspective on our journey for an accurate diagnosis. Next slide, please. Late last summer, my family received devastating news. Our youngest daughter, Ella, was diagnosed with a rare disease called Rett syndrome. Rett syndrome is a rare genetic neurodevelopmental disorder. It typically becomes apparent after 6 to 18 months of age, almost exclusively in females. The condition affects 1 in 10,000 births. It is characterized as the loss of spoken language, repetitive hand movements, difficult motor planning and coordination. There's complications that include seizures, scoliosis, osteoporosis, and sleep disturbances. There is no known cure for Rett, and the prognosis is unknown. Next slide, please. Early in Ella's development, we were concerned as we noticed that her progression was slower than her peers. Those missed milestones caused us severe anxiety. Before her third birthday, Ella stopped sleeping throughout the night and started having recurring tremors. Her behavior changed dramatically, which prompted us to seek medical attention. Many providers at this point chalked her behavior up to the terrible twos and that she was experiencing simple night tremors. Her lack of communication sparked the attention of her new pediatrician, who thought this was autism. A referral to the developmental pediatrician was made, and the wait time was another 14 months to get in. A diagnosis of autism and global developmental delay was received from that appointment. Now that we had a direction, my husband and I did what any loving parent would do at this point. We paid out of pocket and took time off work to jumpstart private therapy at home with OT, PT, speech and language, and ABA. With little to no improvement, we started questioning why. A few months later, Ella lost all her fine motor skills and started posturing and wringing her hands. Her 50-word vocabulary was lost. She stopped walking and had a difficult time eating. We rushed her to the emergency department where she was admitted for observation. The neurology and genetics teams were consulted and offered us insight into what was happening. Ella's constellation of symptoms were pointing to an underlying genetic disorder. At this point, they offered us a blood test to rule out a gene mutation, and it took another 4 months for us to find out that Ella has a MECP2 gene deletion. This is an essential protein that enables your brain to communicate to the rest of your body. After 3 long years of appointments, therapy, anxiety, stress, and crying, we now know that our daughter is literally trapped in her own body. It's incredibly frustrating that all this time had lapsed before the pieces were finally put together. The question that burns in my mind is how much better my family's life would have been if we knew day one. Ella was born with this mutation. She didn't develop it. Ella has been suffering in silence. I consider my family luckier than most. I was able to advocate for Ella, ask appropriate questions, and seek the help needed for a proper diagnosis. Next question. Next slide, please. Every day without a diagnosis is a day lost with the child. We should strive to reduce the strain on the healthcare system and look to implement preventative medicine. Awareness strategies and training in rare diseases is needed, along with a system checklist or an algorithm to follow. In a world of cutting-edge technology and precision medicine, we have the tools to do things smarter and faster. We should be offering families upfront genetic consultation and testing. One simple blood sample would have improved the quality of life of so many people living with a rare genetic condition. Medical records should be accessible to all healthcare professionals, and government input and financial aid is required to assist in timely funding for therapies, drugs, clinical trials, and of course, one-on-one support at the schools. Finally, parents should be a part of the decision-making team and have a voice in the process. Next slide, please. This is the main reason I am sharing Ella's story with you. None of us know how long we have on this earth, but for a family with a child with a rare disorder, a confirmed diagnosis changes everything. It gives us the gift of knowledge and time. Knowledge to treat, knowledge to cure, time to love, and time to cherish every given moment together. Because the reality is 25% of the children with rare diseases will not live to see their 10th birthday. Thank you so much for the opportunity today to discuss my daughter's journey with you. Friends, the time for change is now.
Well, thank you so very much, Sabrina. It's so important to understand, as you say, how rare diseases affects the entire family. Yeah, let me ask you, and I think hopefully you were on when I was presenting around the notion of a rare disease strategy. Ontario has, after the working group was put together in 2016, presented a report in 2017 with recommendations. Ontario then went on to set up a working group to actually develop an implementation plan around 3 key areas. One is early accurate diagnosis and referral to genetic counseling. Second was referral to specialists and centers of excellence, and creating a hub and spoke model for centers of excellence. And the third was a patient registry, so that we can actually begin to capture and record all these patients. You know, Ontario itself actually has two excellent sites for Rett syndrome, and one in London and one in Eastern Ontario. You know, would that have made a difference to you if we actually had something that could have gotten you that diagnosis early and then referred to an appropriate site?
Absolutely. I feel that there's just little knowledge out there of all these rare diseases. And I think where we saw the cracks in the system were with all the new learners, and because we were part of McMaster University, it's a teaching hospital, when they did their screening for 18-month wellness checks and stuff like that, I think that's where it started. I started noticing, reflecting back, noticing that learners were assessing my daughter at that point and weren't picking up on things that were actually very apparent. And I think if there was more people that were educated and clinics available, it would have made a tremendous difference.
Yeah. And as you say, you know, Rett syndrome is a rare disease, but it's also one of our known rare diseases. So, and there are definitely, you know, programs around it. I don't know if we have any other questions that have come through that we should be addressing. Otherwise, we could chat a little bit more about where we are now and where we'd like to be in terms of, specifically for us, Ontario's rare disease framework, because we actually have a recommended framework. I don't actually see any questions, but let me just come back in to say that Sabrina and I will actually be at Queen's Park tomorrow for a breakfast in which we've invited all the members of Parliament. We will have representatives from the PC, from Liberal, from NDP, and from the Green Party who will be there with us, hopefully all endorsing what it is we're doing. But really our main message is, you know, Ontario, we have an implementation plan. We really need to make sure that it's going to be brought in. Well, first of all, it needs to be made public. It was never really published because the change in government that took place, and then also to be able to present it. One of the things we're hoping will make a difference for us, quite frankly, is that one of the co-chairs for that implementation committee was, in fact, Dr. Ryan Khan, who, as you some of you will know, has now become newly named the president and CEO of Toronto Hospital for Sick Children. So he's been our advocate for a long time, works specifically in some of these rare diseases, and we're hoping that this will allow us to actually move that forward. Just to say that in Europe, again, as I say, you have 24 centers of excellence around rare diseases. We would love to be able to set up something that would allow us not to have 24 centers of excellence in Canada, but be able to link our centers to international centers. Serena, one of the we have an international conference in May, and we're hoping that one of the specialists that comes over actually are one of the physicians, clinicians who works with Rett syndrome in Australia. And they've done an amazing job in terms of creating a patient registry and also then supporting the research there. And, you know, it's fostering that kind of collaboration internationally. We think that's so important. For people who are not aware, we actually are hosting the first international conference on rare disease here in Canada. With Rare Disease International. So I serve as the chair of Rare Disease International, as well as my role here as president of a Canadian organization for rare diseases. And we represent some 56 organizations, and most of them national alliances around the world, representing over 100 countries. And we will be hosting our meeting here. One of the other things I'll just mention quickly, since we still have a few minutes, is that we are very much part of the international community. Last week, I was down at the United Nations, where I co-chair a UN forum, actually in the United Nations, co-hosted by 15 countries, calling upon the United Nations to include rare diseases in their declaration for health and within their sustainable development goals, and specifically asking the WHO, which is implementing a call for universal health coverage in all countries, asking all countries to implement programs for universal health coverage, and that we are specifically asking that universal health coverage include rare diseases. And I can tell you internationally, the movement is very, very powerful. We heard over and over again from our UN delegates, from ambassadors, from from representatives of permanent missions there, that the Sustainable Development Goal for 2030 for the United Nations is to leave no one behind. That means that we must have strategies spanning everything from health, education, human rights, disability, work supports, all the way through. And that the goal for it is that every single person in the planet ought to be included. And what we have gotten them to say specifically is that leaving no one behind means not leaving behind patients with rare diseases just because their numbers are small, just because their conditions are difficult to diagnose. As powerfully, we've gotten the WHO, hopefully, when they will produce their declaration on universal health coverage in September, it will also specifically recognize rare diseases. Dr. Tedros, who's the Director General of the WHO, has met with us, and we have had from him last year the message again that universal health coverage, that no country can be considered to actually be adequately serving its citizens unless it actually serves those with rare diseases. Being a small patient population, being small in numbers, being difficult to diagnose, being difficult to treat is not a reason not to take care of them. And so we're making a very special case to recognize that, in every single country, regardless of their economic standards, regardless of their status in healthcare, the most vulnerable patients are those that represent the very small numbers in terms of getting diagnosis or getting access to treatment. And as you can hear from Sabrina's story, this is something that we're wanting to address on a universal basis. So Canada has an Ontario strategy. We're hoping it gets implemented, and that we can use that as a springboard for moving things forward. One of the things we're hoping, we've got one pilot program in Ehlers-Danlos syndrome that the minister approved in 2016. What we love to do is not just have 7,000 other pilot programs, but to start to think about clusters the same way the European Reference Network does. And certainly that would include clusters that would cover Rett syndrome. Sabrina, I don't know if there's anything else you want to add. I know that we're running right up against the end of the time here.
Durhan, I did want to try to get to some questions. My apologies. I did try to get the questions in earlier when you broke, but I had muted my own microphone. And
okay. Yes. Sorry.
First off, Sabrina, I just wanted to introduce myself. I'm Doug Maynard from Children's Healthcare Canada. We didn't get a chance to connect at the beginning of the webinar because of the challenges connecting, but I did also want to thank you for sharing your story. It's always so important when we have the opportunity to share the stories of patients and families with our audience. It really grounds what the presentations in the end users, as we often refer to them, but real people, real families, and real stories. And we know it's not easy to share those stories sometimes, but I did want to personally thank you for joining us today and sharing that story.
Oh, thank you. I really appreciate the opportunity. My daughter, unfortunately, doesn't have the voice, but I'm going to be her voice. And as her parents, we need to advocate for her and for other kids, right, that are going through this.
It came in, Sabrina, was for you, just as someone who is part of the system at Hamilton Health Sciences, now having experienced the other side of the healthcare world as a patient or as a family member, a parent of a child in the system. How has this experience changed you as a member of the healthcare system? And what maybe key message could you share with the others in the audience here who are frontline healthcare service providers, healthcare administrators, researchers? How has this maybe changed you as the staff of the healthcare system?
Yeah, it's really different. Oh, I shouldn't say it's really different. I've always advocated for the families that I work for, and always been empathetic for what they're going through. But when it's your child, and you're seeing what's happening directly impact your family, you can really relate at a different level with the families that are struggling with the diagnosis and how to cope and how to actually navigate the system. So I think become more patient, become just advocating for them more. We're doing a lot of precision medicine right now with the clinical trials with oncology. So when they're trying to get samples to be shipped, I'm right in there trying to help them ship samples and try to get them that information needed to get the drugs the proper drugs to access and treat their cancer. So I think I guess these kids become my little Ella, right? I can relate with these families more.
The next question that came in, Durhan, is probably for you. Maggie's saying that her son has SCN8A epilepsy, and she's wondering how someone might go about implementing a natural history study or a patient registry for something like that.
First of all, I think it's important to kind of look and see if there is actually an existing patient registry, because there are many, many patient registries. And what we're trying to advocate for is actually having patient registries that are somewhat common databases. And so that, even if they aren't exactly the same disease, there are common elements on it. That makes it easier in terms of managing it and keeping track of it. I think there, if you want to, I think I had my email address up there previously. If she's interested, she can email me and we can talk about the various, patient registries that are there that might be, I don't know if they are specific to the exact condition that she's had, but we are really looking to, I think, develop what we call much more patient registry platforms where we can put all this information without necessarily all being a specific registry just for that syndrome. So that is, in fact, available. Canada actually is part of a couple of these databases. So again, if you want to send me an email, I'd be happy to try to talk to you in terms of where are some of the places you can look.
Sounds great. And if anyone didn't have a chance to grab your email address or your contact information from the slides, don't hesitate to contact us at Children's Healthcare Canada, and we'll be happy to put you in touch with Durhan. The next question, and we are pretty much out of time. We're just a minute over, so I'll take this one last question, and then after this question, maybe we'll hand it back to both Sabrina and or Durhan to just share with us any closing key messages you'd like to leave the audience with, upcoming activities or research that you'd like to promote or that's coming out soon that may not be available yet that you'd like to direct people to. Just anything you'd like to leave the audience with after we take this one last question. It's sort of a question around. This one's asking, duplication 15q syndrome is the most identifiable cause of autism after Fragile X, is what this the person's suggesting. Saying, why does it remain so unknown among the public? And perhaps that would go for many rare disorders that do have the ability to diagnose and yet still remain unknown. Any thoughts on that, Durhan?
Yeah, many of these, as you say, and I think as Sabrina will know, autism is one of those that actually becomes a default based on symptoms alone. And same as ADHD becomes a default. And I think this is one of our concerns. I can't tell you specifically. Part of the challenge, as you know, is that just having a diagnosis, even just knowing what the gene is not enough to actually get us to that next stage of having research, start to look at the kinds of care that's available. I will say is that we're, for instance, dealing right now with 3 or 4 very ultra rare diseases that are just coming into a new treatment. And part of it is actually being able to attract the interest of researchers and being able to, and that's where registries become so important, being able to have available patients who actually are willing to participate in that research. So much of patient research these days are actually being driven by, the patient organizations and the families themselves. So it's really, when we say we have 7,000 rare diseases, there's probably only about 500 to 1,000 that are the most common, but still trying to get the attention of the researchers is a huge, huge, huge initiative. And hopefully, if people are interested, we are hosting our conference in May. We're going to have several patient families that are going to come up and talk about what they've been able to do to actually organize and to fundraise to actually get research for their specific rare disease. But it is a matter of trying to cut through so much competition for researchers' attention funding, even when you know the cause of it.
Can I also add on to that? I know when I know for us personally, and I know I've heard from other families as well, is that when they do receive the autism diagnosis that they're on the spectrum, they're offered the chance to have genetic testing done. And I know a lot of families decline that. My family was offered Angelman syndrome and Fragile X only. They missed the Rett syndrome diagnosis because they didn't test for it. And I guess if they're not offered the test or if the families are declining, then they're not able to pick up on those very rare ones. I'm not sure if the one you just mentioned, but in that one specifically, if they're not doing the whole genome sequencing.
That's right. And the genome sequencing, though, is a huge key to how we can get there now. I've got somebody who's dying to meet you, Sabrina, because he's involved in a research project that they've just gotten funded for out of the States. And when I mentioned your story, he says, absolutely. It's exactly what they're looking for, is how do you actually create these kind of platforms where actually patients can register the symptoms, register the kinds of medical information they've got, and then get access to the appropriate genome sequencing or exome sequencing that would get them to an absolute accurate diagnosis, and then have a registry where you can begin to collect, those clusters of patients and families, so that when, in fact, we've got researchers who are interested, they have ready access to a patient population. That will actually speed up so much in terms of getting the right kinds of care, and then hopefully moving towards better options in terms of treatments.
Now, having said that, is there a role for the consumer grade genetic testing in this area? I know for most of those tests, the 23andMe and all those things we see advertised, they don't test the full genome, or they don't map the full genome, et cetera. So I don't know if those consumer level genetic mapping services would capture these kinds of disorders, but just your thoughts on these consumer level genetic mapping services as having a role in identifying these disorders.
Yeah, they're probably better for things like ancestry. Certainly the 23andMe, which does offer some of the medical information, will give you to many more of the common disorders, but certainly are not going to get you to this.
All right.
So if you've got unusual symptoms and you want to get a diagnosis, don't count with 23andMe.
All right. And with that, I think we will wrap up. So we'll hand it back over to both of you. If there's anything you'd like to leave the audience with, Durhan, maybe we'll start with you, and then we'll go to Sabrina to wrap it up. But anything you'd like to leave the audience with before we close off?
No, just huge thanks actually to you, Doug, and to the Children's Healthcare organization here for giving us the opportunity to present this. Really a shout out to say, if you're interested, look on our website. We've got conferences coming up. We've got a lot of educational materials. And one of the big areas that we're really excited about is looking at cell and gene therapy, because this is going to be the answer. So getting a diagnosis, getting a genetic diagnosis, but then being able to match it with, this burgeoning field in terms of gene therapies is absolutely, I think, the next turn in terms of what we can do here.
Any last words before we close off?
Yeah, I think I'm going to echo that. Thank you so much for the opportunity. I'm looking forward to what's going to be implemented from this session. And really, I think as a parent, I just want everybody wants the same thing. They want the best for their child. And I want my child's life to have some meaning. And I hope that this could be a part of her legacy, that things change for newborn screening, and that families can actually receive a diagnosis sooner and can actually spend time with their children, and as opposed to spending time at appointments and the strain that puts on the families. So thank you very much.
Oh, wait, I forgot one last thing. Of course, we're right at the point of having the creation of a new health, this Ontario Health. Well, we would love to have everybody who's advocate that within Ontario Health, we actually have the implementation of Ontario's rare disease framework, and that we actually consider how we have specialized, services for rare diseases within that whole complex. So this may be an opportunity. Since we're dismantling the system, it's an opportunity to putting something that works for rare diseases.
Yes, that's a very good point. The time of change is upon us in Ontario here, so perhaps this is an opportunity. So with that, I think we will wrap up. So thanks again, Durhan. Always great to have you speak. You've been at our conference. You've been on previous webinars. You always bring so much information, and really this time really showed us where we are as far as this vision of a national and a global vision for rare disorders. And Sabrina, again, thank you so much for sharing your story. We value that. We value that so much to hear from patients and families, and especially people like you who have seen both sides and can bring such an interesting and unique perspective. We do our webinars every Wednesday, as most people know, at 11 a.m. Eastern time. And when you do get to watch live, you do get to contribute your questions and comments to the discussion. But when you can't watch live, we do record these sessions and make them available after the fact. the folks that registered for this webinar will receive an email with the link, etc., to find those recordings. And please don't hesitate to share those with anybody that you would like. They're always made freely available and open to the public. Next week, we do not have a webinar next week. We are off for March 6th, but we will be back March 13th with a session called Understanding the Impact and Pathways of Intergenerational Trauma and Resiliency on the Mental Health and Wellness of First Nations Peoples in Canada. CAFC, Children's Healthcare Canada, has had the health of Indigenous children and youth as one of its priorities for a few years now, and it's our pleasure to bring Dr. Robin McQuaid to talk about health and wellness of Indigenous peoples in Canada being impacted by the intergenerational consequences of government policies, et cetera, and just give us a sense of how they use population data to examine the link between residential schools with current day mental health and resiliency among First Nations peoples in Canada. So it'll be a great session in 2 weeks on March 13th. So thanks again for everyone for joining us today. Thanks again to Durhan and Sabrina, and hopefully we'll see everyone back here on March 13th. Goodbye, everyone.